control. So my name is Nicole Spear from the Reagan-Udall Foundation. This is the first time we're doing these calls on a Friday, so first thank you to everybody who adjusted their schedules to join. We're going to keep this I mentioned we were going to keep it on mute. I had a couple announcements I just wanted to kind of do at the very beginning. On May 15th, the Reagan-Udall Foundation is hosting its open annual public meeting, and so we would like all of you to attend if you wish. There's a way to register through an Eventbrite link that's linked through the Reagan-Udall website under the announcements page. So please take a look at it. It's May 15th. The open public portion is going to be 10 to noon, and we'd love to have you guys join us. Also, last week, the IMEDS program released 2 requests for proposals. These are regarding work on 2 of the projects outlined in the 2015 research agenda. So if you didn't get that email notice, I wanted to alert you guys that that information is up under the announcements section on the IMEDS website. So take a look at that. Any luck, Susan, on your end?
No, it keeps shutting down for some reason.
Okay. Do you want to do you have the slides at your?
I do. I will do it that way.
We can actually. I'm happy to move the slides from our end. If you can just say slide or slide number 2 or something like that, we can control it that way. If that works for you. Great.
That'd be great. Thanks. Okay.
Great. So with us today, I'm just going to do a brief introduction, is Susan Andrade. She's she's a lead researcher from Myers Primary Care, and she's going to give us an introduction and update on the MEPREP program, which stands for the Medication Exposure and Pregnancy Risk Evaluation Program. So those slides were sent out ahead of time. If for any reason you didn't get them, just let me know. In a few days, we'll post them along with a recording of this call on the IMEDS website under presentations. And with that, I will turn it over to you, Susan.
Okay, thanks. And again, thank you for inviting me to present this morning. And again, for this webinar, I'm going to be providing an overview of the Medication Exposure and Pregnancy Risk Evaluation Program, or MEPREP. Next slide, please. Now, MEPREP is a pilot program supported through contracts from the FDA. Okay, can you go to the next slide, please? Now, again, this morning I just want to provide an overall description of MEPREP, the MEPREP datasets and characteristics of the population included in MEPREP. And also I am going to be providing some information on the activities and some studies conducted by our group. Now, the next slide, please. Now, the interest in such a program really relates to the fact that prior research has indicated that the majority of women in the U.S. Do receive prescription medications during pregnancy. But as I'm sure most of you know, the knowledge of the safety of most medications for use during pregnancy is really very limited. So in the U.S., health plan data are actually increasingly being used to conduct studies of medication use during pregnancy and birth outcomes. And as far as health plan data, I'm referring both to insurance claims data as well as records that document healthcare delivery obtained through the electronic medical record, or EMR data. Now, again, the information on health encounters as well as prescription data is recorded as part of clinical care. So this would avoid recall bias that you may see in studies that rely on parental recall or questionnaires. Also, with using health plan data, there is a potential to link the data to EMR data and birth and fetal death certificate data. So this allows researchers to obtain information that's not generally captured or may not be completely captured in the health plan data. And again, with the EMR data, you may be able to capture laboratory test results and vital signs data. And with birth certificate data, there are a number of confounders, such as race and ethnicity you can capture, as well as actually information that's really pertinent to the birth, such as birth weight or gestational age at birth. Next slide, please. So, MEPREP is a multi-site collaborative research program between the FDA, the HMO Research Network, Vanderbilt University in Kaiser Permanente, Northern and Southern California. Next slide. Now, the program was developed to provide a mechanism for collaborative research, again, to address the safety of medication use during pregnancy. Next slide. MEPREP actually includes 11 distinct health plans within the 3 FDA contract sites that I mentioned before. And these health plans include 8 members of the HMO Research Network, Tennessee Medicaid, and Kaiser Permanente, Northern and Southern California. Next slide, please. And this next slide, actually, you can see the geographic diversity of the health plans a little bit better. The health plans are located in 9 different states across the U.S. And at the bottom of the slides, I have noted that actually one of the sites is still maintaining the MEPREP data sets, but actually as of the last month or two, they're undergoing a restructuring. That's Kaiser Permanente, Georgia. And so they're hoping to start participating again in MEPREP activities after they're done with their reorganization. Next slide. Through MEPREP, we've developed maternal and infant record linkages of women who delivered a live-born infant between January 2001 and December in 2008, and the children born to these women. Next slide. Okay, at the start of the development of MEPREP, we actually spent quite a bit of effort to determine the governance of the program, including the organizational structure and study policies. But I am not going to be going through the governance issues on this call. I really want to concentrate on the second half, the creation and maintenance of the standardized data sets and the uses of the data. Next slide. Again, as far as development of the standardized data sets, at the start of the program, we developed a data extraction process for identification of mothers and deliveries and infants. This includes mother and infant linkage methods and study ID creation. And we actually also spent quite a bit of effort into developing data file specifications and actually documenting all this information. Next slide. The process for identifying mothers and deliveries actually varied across the MEPREP sites. At Kaiser Northern and Southern California, mothers and infants were identified through pregnancy registries that are maintained at those sites. And these 2 sites actually own both the clinics and hospitals where members receive care. So these pregnancy registries are believed to be very complete. At Vanderbilt, the researchers used birth certificate data obtained from the state of Tennessee and linked this birth certificate data to the Medicaid enrollment files. And they use a probabilistic algorithm to identify and link these mothers and infants. And then finally, at the HMORN sites, the administrative claims are used to identify deliveries. And then the mothers and infants are then linked using either health plan subscriber numbers, names and address matching. And at 2 of the HMRN sites, the birth certificate data is also actually used to help link additional moms and babies. Next slide. The data file specifications for MEPREP were developed using the HMRN Virtual Data Warehouse as a model. And for those of you, and I think many of you are familiar with the Mini-Sentinel Common Data Model, which again is based on the VDW model. So again, all these different programs, the VDW, MEPREP, and Mini-Sentinel Common Data Model, the models look quite similar. So just to briefly go through, the sites actually, for this type of model, create and maintain files of medical care utilization, patient demographics, and other dispensing information, and they maintain these files in standard file formats that remain at the individual sites. But using this distributed model actually allows more efficient querying of the data, since one lead programmer develops the work plans and the SAS code that they distribute to all the sites that participate in the study, and then the sites can run this distributed program. And so the programming activities are actually pretty consistent and efficient using this model. And it also allows all the sites to retain or have all their data remain at their sites. Now, as far as MEPREP, these standardized data files actually contain information for linked mothers and infants for the period 2000 through 2008. And this allows data for 1 year prior to the first possible delivery, which we've identified as 2001 for MEPREP. Next slide, please. There are 9 files maintained for the linked mothers and children at each of the health plans. And these files include a mother and infant linkage file, files for demographic information, health plan membership information, pharmacy dispensing data, diagnosis information, inpatient stay dates and facility information, and procedure information. And all the files I've just mentioned actually are created using the health plan data. But we also have in MEPREP a birth certificate data file, which includes the birth certificate data obtained from the State Departments of Public Health. And again, we have over 100 different variables in this file. And then finally, there's a crosswalk file that links the patient medical record number or the health plan identification number to the study ID that we use for all the other MEPREP files. Next slide. Now this slide just really further describes the data elements that are included in each of the MEPREP files. And again, you can see the study ID links all the files and is included in all the MEPREP files. Next slide. Okay, so we currently have data on about 1.2 million children born to over 900,000 mothers in the MEPREP pilot. And about 43% of the population is from the Kaiser, California sites, 33% from Tennessee Medicaid, and 24% from the HMORN sites. Next slide. This slide presents the distribution of maternal age at delivery for the MEPREP cohort. And the distribution of maternal age at delivery is actually very similar to that of the overall U.S. population of women delivering a live-born infant. However, it is important to note that the proportion of younger mothers in MEPREP is actually larger than we found in earlier HMORN studies, and this is really due in large part to the inclusion of the Medicaid, Tennessee Medicaid population, which again tends to be a younger population. Next slide. Okay, at the initial stages of development of MEPREP, we decided it was important to validate select data elements through medical chart review. And these included select birth outcomes and maternal diagnoses identified from the health plan data, and it also included data elements in the birth certificate data. And again, these data elements from the health plan data included cardiac defects, anencephalus, preterm birth, neonatal intensive care admissions, maternal diagnoses of asthma and lupus. And for the birth certificate data elements, we looked and validated gestational age, birth weight, race, number of previous pregnancies, and number of previous births. And to validate the outcomes, we selected a random sample of medical charts for review for the infants and mothers who are identified with an outcome of interest. And then for the infants who are identified with a birth outcome, we also abstracted information on the maternal and paternal and newborn characteristics so that we could get information to validate the birth certificate data elements. Next slide. I'm not going to go into the results. I'm just going to go through the key findings of what we found from this study. Basically, we found that the health plan administrative and claims data were found to accurately identify infant outcomes, including some specific cardiac defects, preterm birth, and admission to neonatal intensive care units. And as far as the cardiac defects that had high PPVs, they included ventricular septal defect, persistent fetal circulation, and another birth outcome of preterm birth had a high PPV. And again, the maternal diagnoses had high PPVs, asthma and lupus. And again, the PPVs for these outcomes were generally higher than 85%. Actually, most of them were greater than 90%. We also found that the birth certificate data were useful to identify infant birth weight, gestational age, and race and ethnicity, as well as prior obstetrical history. And again, the agreement or PPVs were generally higher than 90% for these outcomes. But we also found that it was important to select the relevant setting and data resources to identify the outcomes and diagnoses. Just as far as one example, we did try to validate codes for anencephaly, but we found actually a very low PPV of 37%, and we were kind of surprised by that. But we saw that most of the diagnosis codes for anencephaly were actually found in the ambulatory care setting, and the PPV for these was only 6%. So that was really what brought the PPV so low for anencephaly. Next slide. Okay. We've also conducted a number of studies evaluating the prevalence of use of medications during pregnancy in our population. And specifically, we've looked at the prevalence of use of antipsychotic medications, anti-epileptic medications, anti-diabetic medications, antiviral agents, and asthma medications. Next slide. So in the next few slides, I'm just going to present some highlights of two of these analyses, just so that you can get an idea of, the patterns and diffusion of the use of the medications in the MEPREP population. Now, the first study was led by Darren Toe at Harvard-Pilgrim, and he looked at the prevalence of and trends in use of antipsychotic medications during pregnancy. And this study included women who were enrolled with prescription drug benefits during the 6 months before pregnancy through the date of delivery. And medication use was, or exposures were determined using the dispense dates and day supply information and pharmacy dispensing files. And what we found was that the use of atypical antipsychotics during pregnancy actually increased about 2.5-fold between 2001 through 2007. And from the slide, you can see this was about 0.3% of deliveries in 2001 to about 0.8% in 2007. Now, in contrast, the use of typical antipsychotics actually remained pretty stable over the same period at about 0.1% of deliveries. And for these analyses, I just should comment quickly that we didn't include prochlorperazine and promethazine because these agents are really more commonly used as antiemetic agents in the pregnant population. We did see that the overall use of prochlorperazine and promethazine was about 10% of pregnant women in our population. And then finally, we saw that depression was the most common mental health diagnosis among women exposed to atypical antipsychotics, and also women exposed to typical antipsychotics. Next slide. This slide presents the prevalence of use of atypical antipsychotics and it looks at the 60-day period pre-pregnancy as well as any time during pregnancy and across the 3 trimesters. And as you can see, the most commonly used agents were quetiapine, olanzapine, and risperidone. Also, if you look at use across the periods of pregnancy, you'll notice that use in the pre-pregnancy period and in the first trimester for all antipsychotics as well as each of the individual agents, the use was higher in the early pregnancy and pre-pregnancy period compared to in the second and third trimesters. Next slide. Okay, in another study that was led by Jean Lawrence, the prevalence of use of anti-diabetic medications during pregnancy was evaluated. And I know this is a busy slide, and unfortunately I can't point to things. But again, the prevalence of use was a little over 1% of women in the pre-pregnancy period and in the first trimester. And you'll notice that use was higher in later trimesters, about 3%. And again, this would be expected because gestational diabetes is diagnosed later in pregnancy. And you'll also notice that for the pregnancy period, insulin was the most common agent used, or insulin products were. And then while metformin was actually the oral agent with the highest use pre-pregnancy, we actually found that most of the women using metformin had a diagnosis of polycystic ovary syndrome or infertility. So again, this really suggests that metformin was likely not used in the treatment of diabetes. And then the most commonly dispensed oral agents in later pregnancy were the sulfonylureas, and these were dispensed to about 0.8% of women. Okay, next slide. Okay, this slide shows the trends in the use of anti-diabetic medications for the 4-month period before conception, looking at the period 2001 through 2007. And overall, again, in this pre-pregnancy period, you can see that there was about a 2.5-fold increase in the use of the medications. But again, this was largely due to the increased use of metformin, which increased 3.8-fold. And the use of insulin and other agents actually was relatively stable during the period 2001 through 2007. Okay, next slide. Now this slide shows the prevalence of anti-diabetic medication use in the second and third trimesters of pregnancy. And again, this is later in pregnancy. And again, as you can see, the overall use increased 30% from about 2.8% in 2001 to about 3.6% in 2007. And this was largely, again, just due to an increase in one drug class, the oral agents. And again, this was mostly the sulfonylureas. And these increased 2.8-fold from about 0.3% to 1.1%. And then again, in the second line, you can notice that the use of insulin products actually decreased a little bit, 13%. Okay, next slide. Okay, so in this slide, I've just presented the citations for the studies I've mentioned, as well as other prevalence and validation studies that have been published by a group so far. Next slide. Okay, we've also conducted a study of sulfonamide use during pregnancy and the risk of select congenital anomalies. And again, this is using the MEPREP data. This study was led by Craig Hansen at Kaiser, Georgia. And we have submitted this study for publication. Next slide. The specific aim of the study was to evaluate the association between maternal exposure to sulfonamide antibacterial medications during pregnancy and select congenital anomalies among live-born infants. Next slide. Okay, so using the MEPREP data, we conducted a retrospective cohort study, and the study population included singleton live-born infants between 2001 through 2008. Next slide. The exposed groups included an exposed group with first trimester exposure to sulfonamide antibacterials. We then identified two comparison groups, and the first comparison group included those with first trimester exposure to a penicillin or cephalosporin antibiotic. And we considered this the primary comparison group of interest, since, again, this group would include women receiving antibacterials used to treat similar indications as sulfonamides. And so we hoped that this would help minimize confounding by indication. We also identified a second comparison group that included women with no antibacterial use in the first trimester. Now, women in the comparison groups were randomly matched one-to-one to the sulfonamide-exposed women by age as well as health plan. And again, we identified exposure to the drugs using the pharmacy dispensing files, both the dispense dates as well as the day supply information. Next slide. Okay, the congenital anomalies of interest included those birth defects that were previously reported to have a potential increased risk with exposure to sulfonamides in previous published studies. But again, the evidence is contradictory about the associations. So the anomalies of interest included cardiovascular abnormalities, cleft palate and/or cleft lip, neural tube defects, clubfoot, urinary system anomalies. And we identified the outcomes using diagnosis codes in the health plan data as well as birth certificate data. And we looked up to 1 year after the baby's date of birth. We then performed chart reviews and adjudication and confirmed all cases. Or we confirmed all cases that we included in the analyses, I should say. Next slide. Okay, this slide actually just emphasizes that MEPREP is a distributed data network, and it describes the general process for data extraction. Again, there is a lead site that develops the work plans and SAS code to distribute to the 11 MEPREP sites, and this is after the IRB approvals and the data use agreements are in place. And so each of the sites runs a SAS code, then they return the data to the lead site who performs the quality checks and final analysis. And for prior MEPREP studies, only aggregate data was returned to the lead site for the compilation and final analysis. But for the sulfonamide study, we actually did send back person-level de-identified data to the lead site for the final analysis. Next slide. Okay, to determine the association between sulfonamide use during pregnancy and each of the congenital anomaly groups, we used multivariable conditional logistic regression. Again, as I mentioned before, the primary comparison evaluated in utero sulfonamide exposure to matched infants exposed to what we're calling non-teratogenic antibacterials, which again were penicillins and cephalosporins. And then there was a secondary analysis that compared the infants with in utero sulfonamide exposure to matched infants not exposed to any antibacterials during the first trimester. And the models were adjusted for infant sex, parity, maternal race, and dispensing of other medications containing a sulfur moiety. And these factors were actually selected a priori based upon the published literature. Okay, next slide. I'm actually going to skip over this slide basically because of the small font, but also, again, it just goes over the selection process for the final cohort. The MEPREP databases include 1.1 million single-tone deliveries, but if you go to the next slide, please. For the final cohort for the analyses, we found that there were 6,688 sulfonamide-exposed women, and again, they were matched to 2 comparison groups. So the final cohort included a total of 20,064 mother-infant pairs. And these were the mother and infant pairs with complete data on the variables used in the main analyses. Next slide. Okay, this slide describes, again, the results for the primary analysis. And again, the primary analysis looked at sulfonamide exposure, and the comparison group was exposure to other antibacterials. And again, as you'll notice, sulfonamide exposure was not significantly associated with a risk for any of the congenital anomalies. And there was an elevated adjusted odds ratio for clubfoot, but as you can see, that again wasn't statistically significant. However, again, if you look at the confidence intervals for both clubfoot as well as cleft lip and palate, they're actually very wide. And again, that's due to the small number of cases that were confirmed. Next slide. Okay, in the secondary analysis, again, that compared the sulfonamide-exposed infants to those with no exposure to antibacterials, you'll notice that the adjusted odds ratios were actually all greater than 1, but again, they weren't statistically significant. Okay, next slide. Okay, so as far as the conclusions for the sulfonamide study, what we found was that there was no difference in the risk of congenital anomalies in live-born infants exposed to sulfonamides during the first trimester versus those exposed to penicillins or cephalosporins. We also believe that our study highlights the need for studies using an active comparator group. Again, for our study, the primary comparison group was mother and infant pairs exposed to antibacterials that had similar indications as sulfonamides. And again, we chose this group specifically in the hopes of minimizing confounding by indication. Okay, next slide. Okay, so as far as the overall strengths of MEPREP, the population encompassed by the MEPREP program is large and both ethnically and geographically diverse. The data allow for large cohort studies of medication use in pregnancy and birth outcomes. The data also allow for the assessment of an overall safety profile for specific medications. And in addition, for those patients with continuous enrollment, outcomes aren't just restricted to the perinatal period. In other words, they're not just those congenital anomalies that would be detected early after birth. There's a potential for long-term follow-up of the children. Also, data on medication use and diagnoses are collected as part of routine care, and so, again, we're not relying on parental recall of the exposure. And then I didn't include it on this slide, but we also have the ability to collect data from the actual medical records. And again, this data might include laboratory test results and vital signs data. Next slide. Okay, there are also obviously a number of limitations with the data. Right now, the data only include information on live births, not all pregnancy outcomes. But we are actually currently evaluating the usefulness of health plan data to identify other pregnancy outcomes in other projects, not MEPREP projects, but other projects we've got funding for. And again, these other pregnancy outcomes include stillbirths, elective terminations, ectopic pregnancies, and also spontaneous abortions. So again, we're hoping that we can use this information if we expand MEPREP later. Another limitation is that we have limited information on some confounders. Again, I mentioned that we have linked to the birth certificate data to obtain information on confounders that aren't available in the health plan data, but there are still some confounders like alcohol use that we really don't have complete information on. Actually, the data is very incomplete for alcohol use. Another limitation is that we capture outpatient medications only, so there is incomplete capture of inpatient and over-the-counter medication use. The data for the pilot only captured deliveries through 2008. So again, these data are really getting outdated, and this is of particular concern if the interest is in the safety of more recently marketed medications. And then finally, the sample size is insufficient for evaluation of many specific medications of potential interest. And again, if medications aren't used that often in the overall population, you can imagine that they'd be used even less in a pregnant population. So again, there are many medications that we really couldn't study with the current population. Next slide. Okay, so from a regulatory perspective, the data are of interest since they do allow evaluation of the patterns and trends in medication use during pregnancy, patterns and trends in birth outcomes, the association between specific medications used during pregnancy and birth outcomes. And they also would allow for the risks and benefits of medication use for the pregnant women themselves. And again, we haven't really used the data for that last purpose yet. Okay, next slide. Okay, so as far as future directions, we're obviously hoping to develop this pilot program into a full-scale program, update the data as recently as possible, and expand the program further. And by expanding the program, we're also hoping that that we can potentially link the MEPREP datasets to other external datasets, for example, mothers and infants' death certificates and cancer registries. And then finally, we're hoping to partner with additional sites to increase the sample size. Okay, next slide. Okay, I guess that's thank you. And again, I apologize for the technical difficulties.
Oh, no, it's nothing on your end. This webinar system's a little funny. Well, thank you so much for that wonderful presentation. I think everyone would agree that this is a unique and valuable set of data. I'm going to go ahead and have Christine unmute everyone at this point, so you'll hear a message, and then please keep
The conference has been unmuted.
And then please, at this point, just keep your phone muted from your end. But this should allow everybody to speak. So if we want to take the last 15 minutes or so, if you can just announce yourself, unmute yourself, and go ahead and ask Susan anything you would like.
Hi, Susan. This is Bin Kai from Pfizer Epidemiology. Can you hear me all right?
I can.
Oh, thank you. And in one of your slides, you mentioned that the claims database can accurately identify outcomes of the babies. And I'm wondering if this is a general statement or you were referring to some results of the study publications?
I was actually just really, again, referring to select outcomes that we've been able to validate so far. And again, there were some cardiac defects, ventriculus septal defect, preterm birth, and persistent fetal circulation that we actually did find that there were high PPVs for. But no, that's not a general comment because, again, as I mentioned, when we looked at anencephalus, we found a low PPV for that outcome. And I know there have been at least a couple of other prior studies, one by Bill Cooper on the Tennessee Medicaid, that have looked at different outcomes, and the PPVs actually vary greatly depending on the outcome.
I see. Thank you.
A question from Rita Willett-Helston, FDA. Susan, you mentioned that the gestational age was validated, and many of the sites use the state birth certificates to validate the gestational age. Have you done any work comparing gestational age determined by ultrasound with gestational age obtained from the birth certificates?
Do you know, we actually, with this, the data when we looked at the medical records for this period of time, and this may be changing a little bit, a lot of the estimates for gestational age didn't specify if it was ultrasound, LMP, or just the clinical or obstetric estimate. So I really can't answer that at this point, but I know, again, it would be important to look at the ultrasound estimate because that would be considered the best estimate.
Would the HMORN sites have just ultrasounds more than birth certificate data?
Right now for MEPREP, we have the birth certificate data. There are some sites that we might be able to get the ultrasound estimates, but getting it from the electronic medical records may not be all that easy. It might actually be something we have to actually almost manually do, or do through natural language processing or something along those lines.
All right. Thank you.
My name is Lu Ping Zhao, and from Fred Hutchinson Cancer Research Center. I have, this is a great example that how this large big data set can be used to study this rare exposure and rare outcome. A great job, great study. Really enjoy it. And my question is mostly concentrating on the second conclusion. Your study highlighted the need for studying using active comparator group. So that actually, in a way, it highlights the potential importance of the bias. So for a moment, I'm going to sort of ask you the following. Let's assuming that your sample size is sufficiently large, and your result stands, and with significance, in specifically in primary analysis, your association with the clubfoot, for example, with an odds ratio 1.58. Is actually significant. Now this actually is in secondary analysis. It also has the 1.58 odds ratio. Let's say is also significant. So that would be one scenario. And the second scenario is that you have the cleft lips, and basically 0.83 says this is no association. And yet at second studies, you have 1.80. And this is a little bit different now. And what would be your interpretation if in this hypothetical studies, if it turns out the case, let's assume there's two associations I'm identified, say happen to be significant. And basically that in your mind, I think it is a good idea to have comparator group try to control the indication. So my question is that certainly having comparator group is a one step forward in the right direction, but is this actually good enough, or at least this is probably the best we can do with this type of data?
That's actually a great question. I think it gets us at least partway there. And again, for the sulfonamide antibiotics, if you're imagining febrile illness or infections may be associated with some of these outcomes, it seems as if at least if you have, again, the active comparator group that actually you would imagine also has infections because they're using antibacterials, that would actually be a good start. What ends up happening is again, we don't really know the severity of the infections or if all these women had fevers or even, again, with the timing could be essential. Again, if some of the women are using in the first, 8 weeks of pregnancy antibacterials. It may be more important than if they're using them on day, later in the first trimester and day 90. So it's getting us part way there, but it's probably not getting us totally there. And we may want to be more specific with the actual risk periods of interest.
So more specific you get to be, and it will be more challenging, more difficult with this type of the data infrastructures and the source of data, right? Because many of the data probably maybe not as precise as you would like to be. Is that fair? I mean, just I want to kind of understand the challenges ahead of us.
I think as you have, again, I think if you get a larger study population, you can kind of look at some of the issues. As I mentioned, if you have a larger study population, you might be able to refine the risk windows of interest a little bit more. You may be able to even do a little bit more with the electronic medical records to see, again, the specific indications for the therapy, or what is perceived as the indications, again, the diagnoses that these women have. So I think you can refine the analyses more than we did at this point. But again, with the numbers for clubfoot as well as cleft lip and palate, we just really didn't have the sample size necessary.
Okay. Now, along the same line, I mean, let's say the primary analysis actually does have a significant indication with the clubfoot association, happen to be significant. And now, of course, the FDA is a regular body, and they pick up this report. And what do you think what will be the pushback from industry? And in terms of how you would actually, I mean, obviously no industry would like to see their drug on your list, right? So have but what would be the pushback? I mean, because I'm kind of worried that essentially the issue that you just mentioned, that we are part of the way there and not all the way there, and whether that can be used as a criticism by industry, say, well, the study is not definitive. Is that a concern in your mind?
I think that's more a question for folks at the FDA than for me, because, again, they're going to be looking at the benefits and risks overall. And if clubfoot is such a rare outcome and is not as detrimental as, obviously, the condition being treated, it may be that nothing's done. And again, if folks from the FDA want to comment, that seems like it might be more useful than what I'm saying.
Thank you, Susan. Appreciate it.
Oh, thank you.
This is Susan Gruber from Reagan-Udall. Thanks, Susan, for the interesting talk. I'm wondering if you could maybe comment or enlighten me about adherence patterns in pregnant women and whether that differs across the drugs or the indication for treatment.
I'm not sure if you're talking about adherence or persistence, but overall, just looking at and again, I haven't actually looked within the pregnant population, but again, adherence is a problem just across the board. But as far as persistence with medications, again, other than the anti-diabetic medications, almost all the drug classes we look at, use tends to be higher in early pregnancy, which I imagine is before the woman or the physicians know that the woman's pregnant, and it tends to drop off later in pregnancy. So there's the use is less prevalent in the second and third trimesters. So there definitely seems to be a trend that may not actually be good in a lot of cases, that women are going off their drugs.
Right. Thank you. So then when you interpret study results, is it ever appropriate to maybe just look at drug use in the first trimester or something like that? Does that enter into any of the study questions?
And again, this is what we actually did for the sulfonamide study. And for the most part, if you're looking at the birth defects, you want to be just looking at the first trimester, although there are adverse birth outcomes that can happen just for use in later trimesters.
Okay, thank you.
Great. Anyone else have any questions for Susan? We've still got a few minutes.
Hi, Susan. This is Xiaofeng from Pfizer. Thank you for the presentation. You have a very unique and important data source. I wonder if you can comment about the data access. Is it possible for industry to have access to this data?
As far as the MEPREP pilot, and again, I don't know if any of the FDA MEPREP investigators are on the call, and this relates to the governance issues that I didn't go into. As far as the MEPREP pilot, only because FDA investigators were on the steering committee, there wasn't really the ability to have industry access the data. And that was one thought about how, when we expand the program, what the governance would look like. So, sorry, excuse me.
Yeah, take your time.
Sorry, I have to confess, I've gotten every cold that's gone around Rhode Island. So, so as far as this time, we're having discussions, and as we update the program and expand the program, we're hoping that we can collaborate more with industry.
Okay, thanks.
Great. Okay. Anyone else? All right. Well, I will give you your 5 minutes back. Thank you so much again, Susan. We really appreciate you volunteering to give this talk. We'll have the talk posted to the website probably in the next few days or so, and the presentation will be up there as well. The next call will actually be on May 22nd. We've got the open public meeting on May 15th, so it'll be, again, a Friday at 11 a.m., and we'll send out an invitation for that shortly with the topic very soon. Thank you all again, and we'll talk to you again soon.